Thank you so much for taking time out of your busy schedules to be here. We're going to call the meeting of the Human Services Committee, the California State Senate, to order. We are grateful for your attendance. We do have a quorum. Let's do a roll call. And it is a busy day today, so I know that Senator Liu is currently in elections, and Senator Hancock had to finish her she's chairwoman of public safety, has to finish that meeting, and they'll be scooting over here as soon as possible. I know some of us are going to have to go to other committees to be able to present bills, and want to apologize ahead of time for that as well. Let's please take roll.
McGuire.
Here.
McGuire here. Berryhill here. Hancock. Liu. Wen. Wen here.
Wonderful. Thank you so much. This is an important meeting, and do want to say thank you to the incredible Human Services Committee team for all their work that has gone in today, and very grateful. Thank you so much, along with our sergeants for all the effort that they're putting in today as well. This is a follow-up to our February 24th meeting. This committee held an informational hearing discussing the overuse of psychotropic medication in our foster care system. And we learned some extremely alarming information. It took a Public Records Act request, unfortunately, on the part of advocacy groups in the San Jose Mercury News in order to uncover the alarming extent to which foster youth are receiving not just one, but multiple psych medications. An astounding 1 to 4 adolescents in foster care and 56% of foster youth residing in group homes are prescribed at least one psychotropic medication. Furthermore, for those youth prescribed psych meds, nearly 60% were prescribed an antipsychotic, the powerful drug class most associated with extremely damaging side effects, and 36% were prescribed multiple medications. And I think that we all came to an agreement that it has to stop. 75% of the prescriptions written for psychiatric illness in the population are off-label in usage and are known to have serious long-term and even permanent side effects, including tremors, weight gain, diabetes, heart disease, increased risk of suicide, among others. And only 37% of children receiving anti-psych medications are receiving the necessary medical lab tests and screenings that is essential to protect kids from suffering long-term serious side effects. And we also learned from the Department of Social Services, and do want to say thank you, along with the Healthcare Services Department, that they've been working to begin to address these long-term issues through the Quality Improvement Project, which is compiling data and establishing a series of outcome measurements to help understand the scope of the problem. Additionally, they've recently released a new guidelines for the use of psych meds with kids and youth in foster care. And I want to say again, thank you. I know that we've all had the opportunity to work with both departments, and they're going to be joining us here today so that we can follow up on our discussion from last February and continue pushing forward with serious and concrete changes. Additionally, today we are hearing 4 bills that represent an initial legislative response to this problem. And I say initial because even with these bills, there's a lot of work that is still in front of us, and we have to be committed to seeing this through. We are actively working on legislative solutions to another problem we learned about in February's hearing, and that is of physicians and or medical professionals who treat foster youth who are receiving financial compensation from drug companies far in excess of other medical professionals who do not treat foster youth. To that end, we are working with various stakeholders to find both legislative and non-legislative solutions. And I say that because, if necessary, we will be bringing forward statutory changes that ensure medical professionals treating our foster youth are independent and unbiased, bottom line. And speaking of that, we will be holding a joint hearing with the Senate Health Services Committee in late May or early June to deal with the issue of psych drugs once again, and we'll let you know as soon as that date is firmed up. We should have the dates here coming up in the next few weeks. I would like to be able to invite agency representatives here today. We have Greg Rose, who's the Deputy Director of Children and Family Services. Greg is with the California Department of Social Services, and I just want to say thank you to Greg for his ongoing commitment, along with Lynette Scott from the Department of Healthcare Services for the state of California, and she is the Chief Medicaid Information Officer. We'd like to welcome you up to the dais, please. Hey, how you doing?
Okay. Somehow they, yeah.
We're going to be hearing an update from each of the agency's representatives, but I want to see if there are any additional opening comments from any of the members. Okay, thank you so much. All right, thank you. And again, we're grateful that you're here, and please kick us off.
Thank you, Chair McGuire and Senators. My name is Greg Rose. I'm the Deputy Director for Children and Family Services at the State Department of Social Services. And before I start, just with some brief remarks, I did want to bring greetings and regrets from both Director Lightbourne and Pete Chervenka, my bosses, who had commitments that they couldn't get out of based on the change of the hearing from last week to this week. But they continue to show leadership in this area on our department, and I'm happy to be here today to discuss with you a little bit of an update from last time the committee met, and then answer some questions as you feel. So just to, as you mentioned, the two departments have been working a lot on the quality improvement plan, and you know, this is really about information sharing, educating people, data monitoring, and the prescribing guidelines that you mentioned. And since we met last, a couple of important things have happened. The guidelines, as you mentioned, have been released and were posted on the department's website, and we're working on a more specific dissemination process. We continue to work with our partners at the Judicial Council on the judicial oversight process, the so-called JV 220 process, and there are information that have been provided to the Judicial Council on that, and we're continuing to work with staff on the JV 220 process. Similarly, there have been outcome measures, the so-called HEDIS measures have been identified, and I think Dr. Scott can speak to some of those a little bit later. The Data and Technology Work Group continues to do its work, and we're happy to say that, you know, we have matched data. We've provided some basic data that's descriptive in nature and broken out by age, ethnicity, placement type, et cetera, that the two departments are discussing internally and with stakeholders. Since we met last, the global data sharing agreement has been signed, and the two departments are able to have a much more robust data sharing. Though that data sharing agreement will be made available to counties as well. Not part of QPI, but important to what you said earlier, the departments have also entered into a data use agreement with the medical board. So CDSS, DHCS, and the medical board have come together to address the issue as needed. When we think about some of the information that is being made available to counties, we have matched data related to prescriptions and judicial oversight, the JV 220 process, and we'll be able to make information available to counties where there's a mismatch and be able to look a little deeper at that issue as well. We expect that information to be out within the next few weeks from the department to local government. And similarly, there's a number of measures that have been developed by the expert panel to look at issues related to both psychotropic medication and antipsychotic medication specifically. The Youth, Family, and Education Work Group continues to do its work and has published the Mental Health Bill of Rights for young people in care, and specifically they've also published questions to ask document, and that is provided to young people so that they're able to have better conversations with their doctors, a pharmacist, frankly, the judge, and their caseworker. And there is a detailed dissemination plan for that information as well, using websites, social media, and other venues, including conference presentations, et cetera. So, and all of this is happening at the same time that we are attempting to change the overall child welfare system relative to placements, relying less on congregate care and more on family-based care as part of our continuum of care effort. And that effort is being carried by Assemblymember Stone, AB 403, and in that specifically, we expect to build a system that cares and comforts young people who have been traumatized by abuse and neglect, with a decreased use of congregate care, or a specialized use of congregate care, specifically short-term residential treatment centers, and youth would be generally served in family-based care in the community with services and supports around them. So that's a basic update of where we are on the QIP work and some of our activities of late.
No, thank you so much. And before we go to questions, if it's okay, we are going to have both representatives speak, and then we'll open it up for questions.
Okay.
All right, that's great. Thank you so much. Please.
Good afternoon. I apologize you did not call my name, but I invited myself up here. I am Karen Baylor, Deputy Director of Mental Health and Substance Use Disorders for the Department of Healthcare Services. And Greg painted a really good picture of all the work that we've done since the last hearing. I think what's important is, now that we have all these data agreements done and signed, and that we're working closely with the medical board, what does this mean now? What are our next steps? And I think really it's for DHCS and DSS to look at how we can increase our oversight and monitoring. I think being able to share data from a variety of sources will help us be able to pinpoint where we think there are some issues that need to be worked out. Part of what needs to happen is actual chart reviews. You cannot tell from just our claiming data whether an intervention occurred or not, or what happened with that intervention. And so we need to be working on how we can implement some of those oversight and monitoring activities into our already existing system, which would be our yearly EQRO reviews, our triennial reviews, and just seeing if we need to work with the county more closely in auditing particular providers. I'm going to turn it over to Lynette now, who can talk about some of the other measures.
Hello, and thank you for the opportunity to be here. My name is Lynette Scott. I'm the Chief Medical Information Officer at the department. And I just want to reiterate what's been said before, that taking care of these children is very important to us. Children are our most precious resource, and as we move forward, we want to make sure they're getting the right care and not the wrong care. And so we want to make sure that we look at this both from the perspective of identifying where there may be too much and also too little. One of the things that we know, there's been a lot of discussion around the potential of overuse of psychotropic and more specifically antipsychotic medications. But we do also want to keep in mind that there are appropriate uses, and that mental health and mental illness is an illness that needs to be treated both with non-pharmacologic treatment, so services that include behavioral, social, and other interventions, as well as there is the right time and place for medication to help people through their illnesses. So we are wanting to make sure that we keep a balance as we look at the data and looking at where the treatment is occurring and how that's occurring. As Karen said, one of the things about our data that we have at the department is that it is administrative data as opposed to treatment data. And to just distinguish there, part of that means what we see is what's being, in a sense, paid for, which is a great way to take a look at how patterns are occurring and where we need to go and look more closely so that we can target scarce resources to really address where the most likely place for issues are. But that doesn't take the place of being on the ground, so to speak, and working with individuals directly and being able to look at that additional detail. One of the things that was mentioned was the HEDIS measures. These are measures that look at healthcare delivery and the quality of care, and we are working on essentially calculating those. There are new measures that came out recently. There's a robust national effort that goes into developing those measures so that there can be consistency and you can compare across organizations and states throughout the country. And so we will be working on measuring those, calculating those, and then being able to share that publicly. And that will give us a sense of how we're doing as well compared to others. At the same time, as was talked about by both Greg and Karen, there's a variety of ways in which we've been sharing data publicly, which the statistics you cited earlier. But we also, again, with the global data sharing agreement, just to pause there, part of what's making that different is that it's focused around the population, the group of children that are in foster care that we are responsible for supporting, as opposed to being about a specific set of data elements. And what that means is that for this case, this example, in the statistical, so that summary data that we can share publicly, it shows that there's a higher use of psychotropic medication in the group home environment. So now what we can do is we can work closely and share that information under that agreement to dive in more specifically to see, are there specific group homes where we see higher utilization, higher use of those medications, and then know that that's where we need to go and target specific assessment. And so those are some of the things that we'll be doing as we move forward in terms of taking next steps, as Karen talked about. The one other piece that we haven't talked about yet today that I do want to highlight as well that was in place at the February hearing, but I think is a very important part of the puzzle, is the treatment authorization requests that are in place. And one of the things is we implemented that last October. We implemented that for all children under the age of 17 that are receiving antipsychotic medication. And because that risk is for all children, not just for foster children. And so we want to make sure we're looking at all of those individuals and that we're assessing their care. As we've been doing that, there's renewals that come around. So we expect another round of renewals for those treatment authorizations. And as we look at those, we'll keep increasing the detail that we look at that, balancing treatment and continuity of care with the medical guidelines and making sure that appropriate documentation is there to support the treatment that's being requested. And that review does occur as the treatment is being prescribed. So it's part of the process in a more real-time way, whereas the other information like HEDIS and some of the statistical measures are in a sense more after the fact. So we really are very serious about continuing to pursue this and understand more about what's happening to our children so that we can take care of them. Thank you.
No, I really appreciate it. And again, I'm grateful that the three of you are here. I just wanted to follow up on a few items. And I think it's the issue of the numbers that we were just discussing and just honing into on the item of foster youth in group homes. I mean, the state has known that the numbers are off the charts for some time. Right? I mean, we've known that. And it took, I guess where my frustration is that it took this coming public to start focusing in on the issue and dealing with it. Because, just real quick, because you mentioned patterns, and I'm not trying to be crunchy, but wanting to be able to advance this because we're talking about the success of individuals throughout their lifetime. That we spend 70% of our Medi-Cal budget for psych meds on foster youth.
So I don't have that number in front of me, so I'd have to check that, but I'm not sure
So
that I know where that number came from.
So that
We can
that
follow up on
is
that for you, though.
a huge concern. And where I want my own personal opinion, I am not a medical professional, but when we take a look at these kids that are in foster homes, they have faced tremendous trauma. And where we have focused as a state, working through providers, is a pill. And a pill won't get them through the trauma that they've experienced. So I think that's where we really need, just hang on everybody, just where I think what we need to be focused is using those dollars that have been going towards those foster youth, and particularly the tens of millions that we're using on psych meds through Medi-Cal and putting it into trauma care. Because I think that we'll actually see an initial increase of what that budget may be, but when it comes to the long term for the individual, we're going to see better outcomes. Any thoughts on that?
Well, Perhaps, and then I'll turn it back over to you. So, one thing, we have been working on this for much longer than the last few years, and it didn't take the PRA to get things started.
Well, we've actually been dealing with this
but-
for 9 years. And the last time we had a hearing on this issue, we've now doubled. So we've doubled. And again, I'm not trying to be crunchy, but my issue is this, is that 9 years ago, we had the same hearing that we had in February. And the only result that we had is a nearly doubling of the amount of psych meds going into our foster system. So when you say we've been working on it, I'm not exactly sure what we've been doing as a state, except drugging our kids with more psychotropic medication. And again, I'm not trying to be crunchy, but I hear what you're saying in regards to we've worked on it. I don't see the results because we've actually, our budget for psych meds and the amount of foster youth on psych meds have gone up over the 9 years that we held the last hearing February.
Okay, let me turn it over to Karen.
Well, I've only been with the department for a year and a half, so I can't speak to what happened 9 years ago, but I do know that
I've
the
only been here for
department...
5 months, and you were at the same hearing I was.
I know.
And so,
I
but here's the
agree.
deal, and I'm not a medical professional, but where my frustration is that we continue to deal with this issue. It's been nearly a decade. How many lives have been lost? And what I mean by that is productive citizens in this state. And that's why I feel extreme frustration. And I also apologize. It's very passionate for myself, and I know for all of you, and you take it very personally.
Yes, we do.
And I think our bottom line where we can find agreement is that we can't let another year, let alone a decade, slip by without real solutions.
Well, and that's what I was going to say, is I don't know what happened 9 years ago, but in my time here, I have seen tremendous movement on this issue and trying to get this resolved. I think we've worked closer with DSS than we ever have before. We've made progress with getting guidelines out there and really trying to turn the curve. I also, as I spoke at the last hearing, talk about I totally agree with you, trauma-informed care is the way to go. And you've got some of the lowest paid people out there working in the group homes that have no training. That is why we are so supportive of DSS moving towards the continuum of care reform,
yes,
because we also think that that's another place where we can make some huge improvements. The fact that we have now the attention of the medical board and their willingness to work with us is another new and change that I don't know what happened 9 years ago, but I've not seen that until recently. So I do think we are changing. Are we there? Have we fixed it? Absolutely not. And I sense your frustration, and hopefully you can see our passion with wanting to get this resolved. But I do know firsthand, years ago, what it's like to work in a group home and have a child who's been through tremendous abuse and trauma go off, and if you don't have the tools, you don't know what to do. And I think that's the focus that we need to have, is make sure that all of these people have been trained in trauma-informed and know how to have a number of interventions in their back pocket so they know what to do when these kids do have these explosive emotions that come out. And anyone who knows, if you've ever been in a traffic jam and you've got someplace to go and you're really fired up, if we would sit down and say to you, how does that make you feel at the moment? You're going to explode and not be able to process. So there's a time and a place and a correct intervention that needs to happen with providing services to these kids. And unfortunately, we've got the lowest paid people providing these services,
And I do
who haven't been as trained as they should be.
Right, absolutely. And I do appreciate Ms. Baylor's advocacy, because it is very personal to you, and I know that. I think the other item that we want to be able to focus in on is that going after where the most urgent need is now. And when we take a look
Absolutely.
at just the numbers, if we're going by the numbers right now, it's foster youth at group homes.
And that's where our focus is as well.
No,
I'm sorry.
absolutely.
Go ahead.
Can I just ask you a quick question in regards to the guidelines? I mean, I guess my issue with the guidelines is they're not codified mandates, right? And essentially being able to guide those providers to be able to do what's best, what they believe is for the kids. And I get it, but I'm worried that if it's not mandated, it may not happen. Can you just go through that and walk us through your thoughts on that?
Do you know?
So,
I'm sorry, I'm
No,
passing
it's
this
okay.
off.
No, it's all good.
the guidelines provide a very, I've talked about this before with others, around a very effective way of creating a common conversation, a common language, a common set of expectations. And that's a lot of what guidelines do. And we have those throughout medicine. Some more recent guidelines that were updated from the U.S. Preventive Services Task Force are making the news now as well. So all of those are, in essence, guidelines around what is the best standard of care. Part of the way that gets enforced is in the clinical environment. Providers and clinics and hospitals introduce that into their standards of practice, and then they hold folks responsible to that in terms of their peer reviews. So there's a variety of ways that plays out. The way that we will be working with the guidelines, in addition to having them be out there and disseminated, is again through that treatment authorization review process. So it also lets folks know that as we're reviewing medication requests as they come in, we will be comparing it against the guidelines and meeting that expectation. And so that's where those two pieces start to play together in terms of both getting the guidelines out around the use of the medications and what's appropriate when, and then as we look at the requests for the medications, as those come in through the treatment authorization approval process, we'll be able to make sure those are being followed.
And I would just like to add that I think this is where we're going to work very closely with a medical board, because if we do find that there is someone who is not adhering to the guidelines, that referral would be made to the medical board.
So I guess the two items, and I just was looking at my notes that I took earlier. So two items is that oversight of the group home program statement, right? And making sure that the individual needs and service plans are followed through on. And the other piece is, how do we oversee the prescribing medical professionals in the group home or FFA environment? Since they're guidelines, right? I just, being able to drill down a little further, because that's really where we have challenges in group homes. And it's potentially professionals that are working for group home organizations or contracted professionals, right? So how do we drill down into that level to ensure that they're fulfilling what we want through the guidelines?
I can speak, this is Greg Rose from the Department of Social Services. I can speak less to the guidelines piece, but clearly, as you mentioned, while we're waiting to kind of change the placement system, we've got youth served in group homes now with the numbers you just described. So we will be using the data that we've talked about earlier to look at group home providers, and then and in our ongoing oversight, be able to provide our staff with additional kind of tools to look a little bit deeper at some of the situations that we see based on the data. So the data would kind of give us an indicator that we might want to look deeper, and then we can go have a on-site look and talk to people about what they are experiencing. And that's kind of the strategy that we think is an interim strategy until the kind of the system changes, if you will.
Okay. So it's a to be determined, right? I mean,
It's a work that in progress,
okay.
and that we now that we're able to look at the kind of the data, as I said, we will have some ability in our typical oversight processes to look at group home providers through a different lens with this additional data. That's not to say that we wouldn't have to do additional training, create some tools, give the workforce the tools they need to meet the expectations that we would have.
Okay. That's great. Thank you so much. I want to see to Senator Nguyen, do you have any items that you would like to be able to discuss? Or okay, thank you so much.
Okay.
Any other further statements?
We're good.
So again, what we're going to be doing is following up this discussion relating psych meds with 4 important bills that are going to be advancing to this committee today. This is a first and important step, but in no means is it the last. And in fact, this is just the beginning of the journey to be able to fix this significant problem that is staring all of us in the face within our foster system. And again, I just want to say thank you to the 3 of you. This is not an easy challenge to be able to find solutions to. We're almost a decade down the road, and the problems has only grown worse. I understand that many of you weren't here when the original hearing, including myself, but it is now our responsibility to be able to fix it.
Agreed.
And I think that is where we are committed. I know all of you in the room are also committed, along with, of course, our esteemed senators as well. And we'll be looking forward to having additional discussions here coming up in late May or June with our Health Services, Human Services Joint Committee. Thank you so much.
Thank
We
you.
appreciate it. We're going to be doing a little bit of a stall here. Senator Mitchell had to leave the room here very quickly. We have 4 bills that are going to be coming up related to psychotropic drugs. We have one focused, SB 238, on the foster care system, in particular adding training for those that are prescribing. We have Senator Monning that will be here in just a bit, focus on dependent children. We do have one related to Mr. Bell, who is going to be bringing forward a bill on child welfare services and public health nursing. And our 4th is also Senator Bell, relating to juveniles and publishing of information about the administration of psych meds to kids living in various types of foster facilities. We're going to just take a quick break, and we'll be back with you in a couple of minutes.